Our next speaker is doing a pre-recorded talk. Her name is Dr. Johanna Clancy. She's going to be talking about her paper, Gripped by the Chaos, a psychoanalytically informed qualitative exploration of adolescent ADHD. Dr. Johanna Clancy is BA Honours graduate, has an MSc and a DClin in psychology. She qualified with a doctorate in clinical psychology from Trinity College Dublin in 2019. She's worked across various clinical settings, including the adult mental health services, children and adult disability services, child and adolescent psychology services, as well as in pediatric psychology and neurology within a hospital setting. She currently works as a senior clinical psychologist in a pediatric primary care service within the Irish Health Service. Johanna has a special interest in childhood mental health, family dynamics, and parenting. She practices adapting an integrative approach, which draws on attachment-based, psychodynamic, and cognitive behavioral models. Her research interests include child and adolescent mental health, early attachment, and maternal mental health, as well as neurodevelopmental disorders. So here's Johanna's presentation, just starting now on your screens.
Hello, my name is Johanna. I am a clinical psychologist working currently in paediatrics within the Irish Health Service. I am delighted to have the opportunity to contribute to this event and to hear that there's such a great space for discussion of very worthy clinical material. I will briefly mention my own background. I have had a very special interest in childhood and adolescent mental health, as well as family dynamics and parenting for a very long time. I qualified as a clinical psychologist in Trinity College in 2019, and I am currently working as a senior psychologist in primary care child psychology services in Dublin South City. This research was actually completed as part of my doctoral studies in 2018-2019 with Trinity and also with St. John of God Services. The focus of my doctoral research was on ADHD and framed through a psychoanalytic lens, which perhaps sounds a little bit different. Over the course of my training, I noticed actually that children and adolescents with ADHD are more than often supported via educational, behavioural and medical interventions. And clinical research typically focused on interventions for parents, interventions for schools, rather than direct therapeutic support for the individual. I have a particular interest in psychoanalytic theory, and I wondered if this type of research might fit with an ADHD population. This particular type of research allows for an analysis not only of content, but also of affect or the emotional content of the interview. There's a focus not only on the words spoken during interview, but also on the experience of being with the adolescent in the room. I was lucky to find a home for this study within John of God Services. Thank you very much to Clodagh Whalon, who is a senior clinical psychologist and worked with me on this project. To give you some background, ADHD is one of the most commonly diagnosed presentations in child and adolescent mental health services globally. However, the stories of adolescents and children also with ADHD are largely absent across its literature. There is huge commentary on prevalence rates, on diagnostic pathways, intervention, often from the perspectives of clinicians and services. There's a hugely high comorbidity with other mental health difficulties, for example, anxiety and low mood or relational issues, and these rates are higher than in the non-ADHD population for adolescents. It's no surprise that these difficulties tend to be exacerbated during the adolescent period. This is a period where internal and interpersonal conflicts and transitions tend to be amplified, and there are also increased expectations for social functioning. Medication is still very much the most common treatment for ADHD. In fact, there's been an 800% increase in this between 1995 and 2015. However, most discontinued this type of treatment by age 21, generally going on with no further support. There's also a 20 to 30% non-response rate reported in the literature, and medication can be insufficient to treat other associated impairments such as mood, anxiety, or relational difficulties. Psychological approaches to adolescent ADHD feel somewhere closer to thinking of the individual within their particular situation, so within family and the wider community. However, the literature is surprisingly sparse when it comes to linking the cognitive, behavioural and the emotional or the interpersonal together. CBT is commonly used, although more so in clients who are experiencing low mood and anxiety. And parenting intervention from a behavioural point of view is also very commonly discussed in the literature, for example, Parents Plus. Social skills training is also very widely considered for ADHD, which is generally in group format and often school-based. There are, of course, some issues with current intervention. Firstly, adolescents are not typically considered equal contributors to treatment plans in many cases, even though often they've demonstrated their capacity for involvement. And it's wondered, could this possibly be why many tend to discontinue with treatment as usual offerings? There seems to be a lack of understanding of what it's like to be a teenager, to have ADHD and to be treated for ADHD. And quantitative research in particular seems to fall short in examining young people's thoughts and their own concerns. So it can be difficult to get a sense really in the literature of the adolescents' emotional needs, particularly if they're not given the opportunity to be decision makers in care planning. I was supported in conducting this research by Dr. John O'Connor, who is a psychoanalyst, a researcher and a psychologist based in Trinity College. And really he brought me to the thinking of exploring ADHD qualitatively through a psychoanalytic frame. There is historically lots of skepticism about the use of psychoanalytic approaches in the case of ADHD across the literature, and psychoanalytic research has been very much critical and uncertain even about the concept of the disorder in general. So typically neurodevelopmental and cognitive models of ADHD prevail, but perhaps could that mean that there be a unique position from psychoanalytic research to offer insight into an individual's experience of ADHD? It also would place emphasis perhaps on how and when an individual's symptoms are connected with emotional pain. And it has less focus on causality and more on the subjective interpersonal experience of the person. So it may be able to make more sense of the emotional impact on these adolescents. There was also the possibility of creating dialogue which values the story of the adolescent client. The study was qualitative in nature using the psychoanalytic research interview method. This involves 3 interviews with each participant, drawing on themes or domains of inquiry, and attention is paid not only to the content or the words used in interview, but also the process, so the emotional atmosphere or the transference while we're analysing data. I recruited for this research through CAMS. I looked at a population of 16 to 18-year-olds who had a current diagnosis of ADHD as per DSM-5. So all participants had ongoing contact with CAMS, and it was also important that they weren't actively suicidal or psychotic and didn't have a comorbid autism spectrum disorder diagnosis, as interpersonal difficulties can also be understood in the context of social communication within this population. There were 5 participants, 4 female and 1 male, all aged 16 or 17. They were all secondary school students, 2 of whom were on reduced school days at the time of the research. All were attending CAMS currently, and some had attended for more than 5 years, while others were attending for shorter periods, so just 1 year. All participants had reported experiencing anxiety or depression at least one point in their lives, and all were medicated for ADHD, though one participant had really recently stopped taking medication due to sleep difficulties. Interestingly, there was no known family history of ADHD for any participant. However, 4 out of the 5 reported a family history of mental health difficulties. Interviews were conducted in CAMS weekly over a 3-week period. Participants talked about their experience of being diagnosed and living with ADHD and anything else that came to mind, and this facilitated an element of free association within the interview, so that there wouldn't have been a huge structure to interviews in this particular method. Questions introduced generally were to encourage flow of narrative, to clarify, to address any striking gaps in the narrative between interviews. And a key component of this particular research method is weekly supervision, which is used to discuss and reflect on interview content, interview process, but also to minimize any unconscious bias that you might have as interviewer. The psychoanalytic research interview method assumes that the meaning or motivation underlying human behavior is not always consciously accessible. So that means there is an equal focus on the emotional content of the interview, which might be unspoken or experienced in the transference as part of the interviewer's own process. So comments on shift in process or dynamic in the interview were recorded in the body of transcripts. So for example, things like pauses, changes in tone, laughing, crying, fidgeting, ending the session late or arriving late. And over the weeks, the data was distilled into 3 main themes. And all of these themes were present in every one of the participants, however, in different and actually often contrary ways. And so the results, the narrative of almost every interview tended to revolve around the interpersonal or the emotional experience of participants, and relationships in almost every conversation that I had were the main focus and the common focus. Discussion of ADHD typically actually appeared in a way to explain behavior, and it was often described as being almost a personality trait for the individual rather than being an externally imposed label or a diagnosis. Participants said that they felt misunderstood in key relationships such as family, school, mental health services, and discussion of painful memories often included feeling poorly connected to others and alone and misunderstood in their emotions. There was a lot of conversation about vacillating or shifting differences in feelings of distress and elation. Theme 1 was not being able to let out difficult emotion, and this theme discussed the idea of a difficult, turbulent inner atmosphere with difficult emotions and the experience of being unable to express or eject these feelings. Participants felt unwanted and overwhelming thoughts or feelings inside, which were difficult to escape from, and this was common amongst them. They talked about being unable to name difficult feelings and the idea of paradoxical experiences, so being unable to focus due to a turbulent inner atmosphere, but also craving a source of distraction from these thoughts came up a lot. 3 of the 5 participants said that their impulsivity actually helped them to avoid feelings, and acting impulsively without thinking actually felt like an escape for them. 4 of the 5, interestingly, described movement or fidgeting, in fact, as soothing or grounding. So one said, "I'm kicking my leg now instead of starting to cry or getting overwhelmed by what I'm talking about. It just calms me." The second theme was unsoothing experience with self and other. And I suppose this talked about the feeling that others can't provide sufficient emotional care or containment during times of distress. Participants talked about how their emotional needs perhaps are misunderstood by others. They commonly discussed histories of being difficult to soothe from early on or difficult to manage, and would have referenced a preference for self-soothing or soothing alone. Many were hesitant to burden others with difficult feelings and afraid that others won't be able to tolerate or cope with their feelings. One participant, for example, talked about being unsupported and alone in her efforts to ease the pain of difficult emotions. She said that for someone to calm you down, you have to feel taken care of, that a person must understand your emotional experience. She said, "I couldn't settle down because I couldn't stop thinking about everyone and everything, and no one was there to help me actually calm down because nobody got it." She said, "It's better for me knowing that I'm not a burden to them than it is actually going to them to get comfort." And there was great sadness in the room, as I'm sure you can imagine, during these discussions around that content. More pause, more reluctance to elaborate. And so I felt this particular methodology was very helpful in helping me to reflect on and really understand the emotional content of this particular theme. Theme 3 referenced the idea of being in and out of control. So there was a very much all or nothing approach to feeling in control or out of control for participants. All of them had a real dread of uncertainty and really felt the need to take control over this, to feel safe. and to feel that anxiety wouldn't take over for them. And interestingly, many would have described impulsivity as a relief or a release from this tense feeling of needing to be in control all the time. Participants also felt angry by the idea of being controlled by others, so whether that was professionals or parents or family. And at this point, and I really reflected in the research that in these interviews, when this thematic material was coming up, I often felt a very strong urge to regain control over the dynamic in the room. So perhaps there might have been an overwhelming sense of anger or anxiety very present. One participant said, "I'm not a control freak, but I feel that the people in my life are taking all the power and it just annoys me so much. I can't actually take it. I do not like being controlled by others. I'm doing my best to control things myself." I'll talk briefly about key discoveries from the discussion of the research study. Themes in this paper really did interlink in their suggestion of disruption in the experience of containment and holding for these participants. What I mean by that is that perhaps painful experiences could not or had not been processed or worked through. In an effort perhaps to tolerate distressing effect, it seemed that a set of psychic coping mechanisms had been developed, and they seemed to take the form of restless energy, and this is the restless energy of their ADHD. A surprising finding was that participants stated a need for and also real efforts to achieve control, so efforts to control inner thoughts often failed, versus a desire also for emotional freedom, and that seemed to come in moments of impulsivity for some, but not all. The research referenced how important it was for participants to feel that others in their lives understand them so that they can get the emotional release or the emotional care that they need. And that suggests perhaps that we need to shift away from behaviour modification for this population more towards a supportive processing of relational distress. Adolescents talked a lot about the idea that they wanted to collaborate, and so the research suggests that perhaps teenagers should be collaborators in their treatment planning for ADHD because they have a level of understanding of what maintains their emotional difficulties. The findings also tentatively suggest that ADHD traits may be understood in emotional terms, so for containing intolerable feelings rather than just as symptoms. And helping the adolescent with ADHD may be best facilitated by a response that attends to their complex or uncontained emotional and interpersonal needs rather than solely their behaviours. In reflecting back on this research now, a couple of years later as a clinician, I'm still really struck by the realisation that really we need to shift our focus to supporting and resolving emotional distress where we can for these adolescents. And that might involve a shifting of parents' thinking on the experiences of ADHD. I think there can be the idea of a diagnosis as a fix, and perhaps we need more of a holistic understanding and a consideration of the child's needs emotionally. And that certainly has implications for my own current practice. So I suppose I really think about holding these ideas in mind while also working within a system that is very, very short on therapeutic resources. And if I think back to the 5 participants that I had in 2019, none of those 5 would have recently been in receipt of one-to-one therapeutic support, but all really felt that they would benefit. And I guess this research really strikes me as bringing the importance of clinical formulation to the front when working within teams, particularly those who support children and adolescents with ADHD, because it really helps us to develop an understanding of the psychological and the emotional process for these adolescents. Thank you very much for listening and for watching. Thank you to Claude Denis Whalon and to St. John of God Services for being so open to this particular type of research. To the participants, they were so honest, they were so brave in the interview process. It was great to meet with them and a great learning for me. And thank you finally for inviting me to participate in this discussion. I have a PDF of the paper if anyone is interested, which includes some useful references, and that is available to be circulated upon request. And please drop me an email if you have any questions or any thoughts. I would be delighted to hear from you. Thank you so much.